Professor Villanova, thank you very much for this very kind invitation. I also would like to thank Professor Ham and Professor Cornu for having me here. It's a big pleasure on behalf of the European Association of Urology, which I'm on the board on, and it's specifically a big pleasure because I was always a big pusher to the collaboration with the radiology departments and with radiologists in general, and that's why I'm very pleased to be here today. Thank you very much. This being said, the topic I was giving short notice, however, was on giving you a little bit of a urological perspective about prostate biopsies. And we heard a beautiful talk just before about the standards that are important when you make decisions on making a prostate cancer assumption. However, all this being said and done, the basis of the diagnosis remains the biopsy. In many countries in Europe today, without a given histological, pathological diagnosis, you're not allowed to treat prostate cancer, whether that is active surveillance or that is surgery in our case. So the diagnosis is based on prostate biopsies. And what I would like to share with you today is a little bit of a urological perspective. Now, in the 80s, when the first prostate biopsies were introduced by Thomas Stamey, for example, in Stanford, the prostate biopsy was a very poor quality sampling. As you can see here, basically it was a transition zone sampling. It's not even a prostate biopsy. They just stick the needle in the rectum of the patient and try just to hit the prostate. And this was all it was for another 20 years. It was basically by the 90s for the first time where urologists learned that prostate biopsies is more than just hitting the prostate with the needle. And if you look at the guidelines, however, and I'm going to be very critical, the American guidelines, this is the AUA, the American Urological Association guidelines for doing prostate biopsies. And as you can see, they have not changed in the past 20 years. So as much as we hear today at the ECR, this information has to be given to the urologist because it should not stick with the radiology department because that's not going to be helpful. It needs to be transported, transfected to the urological community as well. And if you see our guidelines, what they say is, if the digital rectal exam is positive, if the PSA is elevated, then you do a biopsy. And this has been a very low quality, poor information that still is the basis of our guidelines. So I'm being very self-critical now. So the basis of our information is PSA, and the other one, just to wake you up a little bit, the digital rectal exam. And you see, he puts the finger, the digital rectal exam, and then you look at it, and if it works, it's prostate cancer. And if the digital rectal exam is positive, you have to do a biopsy, and if not, you don't. I don't think that this is really standard of care in 2014, it's just to do a finger examination and a PSA. There must be a lot more than that. So if you look at the literature, the urological literature today, the optimal prostate sampling, basically, has been based on these 5 notions. Number 1 was to increase the number of cores. So instead of doing 6 cores in 1980, today we do even 12, 18, and even saturation biopsies. Whether that is smart, I don't think just increasing the number of cores is a smart thing to do. The more you do, the more you will find cancer. But is that really what we want to do? Number 2, we learned, and it took a long time as well, that we have to change the biopsy scheme. Instead of doing transition zone biopsies like Stamey did it in the 1980s, we learned that we have to go more lateral. We have to do the peripheral zone, eventually even also the apex. And that took us, please, 20 years to understand. We're using Vienna nomograms. I'm a little bit self-promoting here because this was my thesis, which combines the volume of the prostate and the age of the patient to determine how many cores you need. But even that is already outdated. You can use new markers. New PSA markers. We have BPSA, PPSA, P2PSA, ProPSA, many new biochemical markers to identify patients who may have cancer. And finally, the question stays there. If a biopsy is negative, what do we do then? When do we stop the biopsy cascade? Because remember, we knew a lot about positive biopsies, as we heard about the pirates now. But what happens with the negative biopsies? How do we academically challenge the issue of a negative biopsy? Nobody really knows because little has been done on that. So one message that we learned over the years is, very stupidly I have to say, more is better. And the number of papers published on that are numerous. And of course, you can see that the more cores you do, the more you will find cancer. That is very clear. But the question really is not only the number, but also to go more lateral, because we know that cancer is in the peripheral zone. Now, you're looking at me because you're a radiologist and you're saying, but this is old stuff. Well, I have news for you. This is not old stuff for radiologists. You still have people in Europe, in Central Europe, doing transition zone biopsies, basically not knowing that most of the cores should be directed to the lateral zone. So there's a lot of work to do still there. Alexandre Delataille did a study in which he basically introduced, back 10, 15 years ago, the notion of saturation biopsy, which basically meant that you take roughly between 18 and 24 cores. The definition of saturation biopsy is still not standardized. But what we learned is, even if you exaggerate the number of cores, the cancer detection rate will never be increased by more than 12%. So in a few number of urologists, the information came through, this cannot be it. We cannot just increase the number of cores because the cancer detection rate will not follow the number of cores. 12% is very minimal in terms of cancer detection rate. And Jones, that is working right now as one of the chiefs at the Cleveland Clinic Foundation, looked at that and showed actually that saturation technique does not necessarily improve cancer detection. It just improves the number of biopsies you do, but in an overall setting, it does not improve cancer detection by such. And finally, a word of caution by Teresa Chan, who said, be careful. Now, you're doing more biopsies, you're doing more cores, but what you're going to do is not find more cancers, you're just going to find more insignificant cancers. So, see, the urology community has been challenged by a lack of academic information about how to do a good biopsy. We looked a lot of that. I've been working on that for many years as well. And one other message we learned in these times is that if you do a biopsy, on the first case, the biopsy distribution around the prostate is all over the prostate. So the chance of finding cancer is the same in all over the prostate if you take it only in terms of statistics. But if you miss, or if you don't have cancer on first biopsy, which happens in about roughly 70% of cases, the second biopsy, if you find one on repeat biopsy, now we see that the cancers are located more at the apex, more dorsally. So we learned also that not all cancers are distributed in the same fashion all over the prostate. And so we need some imaging information to find those missed cancers. This is much more important than actually doing it on a first biopsy setting. And we learned a little bit, and what we did as a urologist, we changed our biopsy technique. Today, we do more lateral biopsies, but we also do more pararectal biopsies, and obviously also more apical biopsies. We try to cover the apex. But you can see that more or less it's a blind endeavor. It's a mission impossible to hit and find all accurate cancers because it's a blind biopsy by all. And one other thing we learned is, no matter what we do, whenever there is a negative biopsy, the way we do it today, not the way you're trying to teach us with you together to do it, the way we do it, and 90% of urologists do it today, is that when you have a negative biopsy, like in 78% on this was a study we published many years ago, probably the largest repeat biopsy study. On the first biopsy, your cancer detection rate is between 20 and today maybe with the extended biopsies, 30, 40%. But even then, those who are negative on first biopsy will have cancer in 10 to 15% on repeat biopsy. So we're always going to miss cancer, and there are very often significant cancers that we miss with our standard biopsy techniques. So the best improvement that we urologists gave to the cancer detection was template prostate biopsies, which is, I think, an extremely, I would say strong, but not very smart reaction to academic failure. Because it's like when you're in war, the more you fight, the more troops you send in. And sending in troops is not the solution. Sometimes you have to find how to eliminate the enemy without sending always more troops in. Template biopsies are what we do today to identify significant cancer and to identify patients for active surveillance and focal therapy, because this is why we are here, at least from our perspective. And template biopsies are just the saturation biopsies from transrectal and transperineal fashion at the same time. This is what a urologist will tell you today he wants. And I personally believe this is not the way to go in the future. Template biopsies need, of course, transperineal approach as well to the transrectal approach. And if you look at on the ROC curve in terms of statistics, how good is the biopsy itself, not the PSA, but the biopsy procedure. Let's say you have 100 patients in which you know that you have cancer. You know that. And if you do a biopsy on these patients, in how many cases will you find cancer? And it's very interesting that the best sensitivity you can get with a biopsy in a known cancer patient is 65%. So in 40%, although you have cancer, you will miss it. And this was done on a computer model in many, many places. One of the first studies was done in Florida about 20 years ago. Now, this ROC curve shows you that in red you have the ROC curve for a standard 12-core biopsy. And you see the ROC curve is in the middle of the page. And for all of you who are familiar with statistics, this means it's a 50-50% chance of identifying cancer. So it's a coin. So actually you don't need biopsy because you can tell your patient it's a 50-50% chance. This being said, the nomograms that we have available today help you a little bit with the age and the size, giving you the number of cores you need. But again, urology today is based on a blind assumption of cancer. And if you look at the literature, and this is a very beautiful bibliographical review done just 2 years ago, it basically says that 12 cores is the best we should do. We can increase it a little bit, but even by increasing more than 12 cores, it will not help increase cancer detection rate and certainly not help you find significant cancer. So this is the best urologists have been doing for prostate cancer detection. The problem and the challenge in 2014 is that finding cancer is not enough. This is a typical pathological examination of a prostate radical prostatectomy. This is actually one of our patients. And if you look at that, you see that prostate cancer is multifocal. You have different areas. As you heard, you can have different pyrite grades in the same patient. So here you have actually a multifocal prostate cancer in which some cancers are significant and potentially aggressive and deadly, and some are totally insignificant. It will not have an impact on the patient's life. How can we do that? And the problem is that up till 2007, the goal of the urologist was to find any cancer. He didn't care what he found as long as the pathologist said prostate cancer. And the next step was radical prostatectomy if he was young enough and healthy enough. This was a very simple vision of the urologist. Today, and this is after 2007, the idea is not to find any cancer. I'm sorry I missed the ages. It should be 2007 to today. The idea is to find significant cancer. We don't want to find every cancer. We just want to find those cancers that we want to treat. And for that, we have requirements. And the requirements is A, adequate detection of the significant cancers. And again, that's why I think pyrites and MRIs and multiparametric MRIs are so important. Accuracy of negative sampling. How do we deal? How accurate is a negative biopsy? Which means that if I tell the patient your biopsy is negative, how negative is he really? And this is a big challenge as well, again, where we need imaging. Number 3, where is the limited detection of clinical insignificant cancers? The problem is that we have a problem in identifying insignificant cancers. And this is a very important tool for us because today active surveillance is a very popular tool in urology. We don't operate every cancer anymore. Many patients go onto active surveillance, which means we don't treat them, we wait, we do repeat biopsies and PSA, and if PSA rises, then we operate. So active surveillance needs an accurate identification of insignificant cancers. Again, it's a very important question to you, a tool for radiology. And it should be good concordance with pathology. And finally, because we do a lot of focal therapy today, we do HIFUs, we do brachytherapies, we also want to know the three-dimensional form of the cancer area that we are looking for. And I'm basically telling you what? I'm telling you that we need more information than just standard prostate biopsies. Today, what a urologist has to know is how long is the cancer core, what is the maximum cancer core length, and what is the Gleason grade, and finally, of course, score of this given patient. So a standard biopsy will not give you that answer. We need more information, and therefore imaging is a big lacking element. So see, the EAU guidelines, the European Urology Guidelines, identify low-risk prostate cancer based on PSA alone. Gleason score less than 6, PSA less than 10, That's low risk. And these patients can undergo active surveillance. The problem is that with the current biopsy technique, the way we do it, urologists do it today, we are very good in identifying significant cancer. The positive, and remember, very important is the positive predictive value, but also the negative predictive value. And the PPV is 78%, which is pretty good. The caveat is that there is only a 48 or 50% PPV for identifying insignificant disease. And my idea is I rather want to rule out the good guys rather just to identify the bad guys. So I have a big problem in statistics with the current biopsy techniques. And negative biopsies, nobody really knows much about them because what it means. Is it negative of cancer or is it negative because the biopsy didn't find the cancer? And this is one of the big problems. And I'm going to challenge the reliability of current biopsy techniques because let's say you have, this is a study of 120 patients who we knew had prostate cancer. And when we basically redid the biopsy in these patients, in only 44% was the prediction correct in terms of insignificant prostate cancer. So the best we can do to identify insignificant prostate cancer is 44%. In 60% or more, or 56% or more, we are totally wrong. The other problem in the area on the curve was 68. The other problem is that on a computer simulation that was done by Le Cornet, you can see here, basically, trust standard prostate biopsy had a very, very poor detection rate. And that was true for the different colors are different sizes of cancer. And you can see no matter where big cancer or small cancer, the detection rate was not very good. It was always around 30%, where we know these patients have cancer, by the way. These are known prostate cancer patients on a computer model. And as I mentioned earlier, even doing more biopsy will increase a little bit the ROC curve, but not to a point where I can accurately tell your patient you have prostate cancer. And this is true for big lesions and even for very small lesions, of course, more even in terms of detection. So if you look at the standard biopsy, which is 12 cores, 47% of lesions, 0.5 ml or greater, and 79% of smaller lesions, 0.2, were missed on standard prostate biopsy. Now, you're going to tell me, well, but you do more cores today. Okay, we call this TRUST opt. Opt is the optimal TRUST biopsy with 18 cores sometimes. And in this case, even with the increased score, you still missed 36% of 0.5 or greater tumors and 65% of 0.2 tumors. So still, increasing the core number does not increase significantly the biopsy. The other problem is Gleason score. How accurate is biopsy in detecting Gleason scores? Because that's what we want, to identify aggressive cancers. It's not good. If you do serial repeat biopsies, you will have still, as you can see, a significant number of patients who will be upgraded. So every time you do a biopsy, in a certain percent of patients, between 10 and 36%, the Gleason score or the grade will become worse. So biopsy is not accurate in identifying Gleason grades. And that's another problem. And this is true because those patients who have an upgrade on Gleason score on repeat biopsies will have a much poorer survival, as you can see here. These patients are with upgrade on biopsy, on repeat biopsy. They have a much poorer survival than those who don't have an upgrade. And this being said, the same accounts for the volume. If you do repeat biopsy, every time you do more biopsies, you will find that the cancer gets bigger and bigger. So at first biopsy, you always underestimate the volume. So you underestimate cancer detection overall. You underestimate Gleason grade. You underestimate cancer volume. And I told you earlier on that this is exactly the three criteria that we need. We need cancer volume, we need cancer, and we need Gleason grade. And TRUST biopsy, even with 18 cores, largely underestimates that. So I'm being very self-critical, but I'm making a case here. And let's say the most simplest question that we have to the urologist is, do you have unilateral disease? Do you have cancer on both sides or on one lobe? And look, these are patients who on biopsy 606 had unilateral biopsies, unilateral cancer on biopsy. And in reality, no matter what stage, grade, or percentage tumor volume on biopsy you take, the best you had was 25%. So only 25% of those patients who were identified with unilateral biopsy, unilateral cancer on biopsy, really had unilateral disease. 80% had bilateral disease, or 70% had bilateral disease. So even that is not good enough for a biopsy. So basically, we can trash, and that's why my talk was, can we trash trust biopsy? And the European guidelines, unfortunately, still do not help us. They still tell us, do 12 cores, do more cores, and go on. This is just a busy slide, but to tell you that urologists are very slowly learning from that information. So the future really should be that we should think about us as somebody who does the biopsy. I'm coming to the end. So what is the core problem of trust biopsy? The core problem is that statistically, the most strongest predictor of cancer detection is the operator, is the doctor who does the biopsy. And this is a nice study that was published in the Journal of Urology. And you can see here, based on 4,000 biopsies, roughly, the operator was the strongest one. I think the future is, and it's very clear to me, and that's what we are trying to promote that in urology. We need badly, for statistical purposes, nothing else, we need imaging information that would help us reduce unnecessary biopsies, increase the detection rate, predict the Gleason grade and specifically cancer volume and the laterality of the disease, bilateral or monolateral or unilateral. And for that, the fusion of TRUS and a multiparametric MRI is essential and crucial. I think I'm going to end with this stuff by Rob Ryder, who said that one of the biggest barriers to effective treatment of prostate cancer is that we have today at least, no adequate way of using imaging in our diagnostic procedure. We need to do that. And I think fusion means not only fusion of technologies, but fusion of two specialties. We need to work together. A biopsy should be a two-departmental matter in which imaging and urology work together. I think this is a very important tool. So to answer my initial question, is it time to trash biopsy? We shouldn't do it anymore? No, that's not what I said. I said that we have to change the way we do a biopsy. Just doing more biopsies and more lateral is not the solution. We need to add imaging information, specifically multiparametric MRI, and we need to learn how to do a good fusion because, I have to tell you honestly, good fusion technology is not yet available. I'm sure I wasn't at your industry booth area, but I'm sure there's a lot of companies offering that. We need to improve that fusion technology. It's not going to be helpful to do great multiparametric MRIs that sound wonderful on a lecture, but do not help us in a clinical pathway when we don't have the fusion. And finally, remember, it's important more than ever to identify the target lesion. I don't want to find every cancer in the prostate. I want to find that one significant one that I need to treat with focal therapy, because the future will not be radical prostatectomy. It pays my personal bills, and I'm very happy about that. But the future will be not doing surgery in many patients anymore. It will be active surveillance for insignificant cancers, and it will be focal therapy for significant cancers in which we can identify the target lesion. And I said to the urologist, I always say that a fool with a tool is still a fool. So and I'm very self-critical, if I'm an idiot and you give me an MRI, I'm still an idiot. Thank you very much.